Okay, so this will be the last video for this cardiovascular section of the USMLE. Hypertension treatment. Primary hypertension, thiazide diuretics, definitely testable on this USMLE. ACE inhibitors, angiotensin 2, receptor blockers, ARB blockers, dihydropyridine, calcium 2 channel blockers. Hypertension with heart failure, diuretics, ACE inhibitors, ARBs, so pretty much the same thing. Aldosterone antagonists. Then you have beta blockers must be used cautiously in decompensated heart failure and are contraindicated in cardiogenic shock. In heart failure, ARBs, the angiotensin receptor blockers, may be combined with the neprilysin inhibitor sacubitril. Okay. Hypertension with diabetes mellitus, ACE inhibitors, ARBs, calcium channel blockers, thiazide diuretics, and beta blockers. ACE inhibitors, ARBs are protective against diabetic nephropathy. Hypertension and asthma. ARBs, calcium channel blockers, thiazide diuretics, selective beta blockers. Avoid non-selective beta blockers to prevent beta 2 receptors induced bronchoconstriction. Avoid ACE inhibitors to prevent confusion between drug or asthma-related coughs. And then hypertension in pregnancy. Hydralazine, labetalol, methyl-dopa, nifedipine. He likes my neonate. Finally, keep going with this. Calcium channel blockers. These are examples of amlodipine, clevidipine, nicardipine, nifedipine, nimodipine, dihydropyridines. Act on vascular smooth muscle. Diltiazem, verapamil, non-dihydropyridines act on the heart. Mechanism: block voltage-dependent L-type calcium channels of cardiac and smooth muscle, decrease the muscle contractibility. Vascular heart, smooth muscle, amlodipine, nifedipine, diltiazem, and verapamil. Heart, verapamil, diltiazem, amlodipine, nifedipine. So V's, verapamil and ventricle. Clinical use: dihydropines, hypertension, angina, Raynaud phenomena, nimodipine, suprarachnoid hemorrhage, preventing cerebral vasospasms, nicardipine, clevidipine, hypertensive urgency or emergency, non-dihydropyridine, hypertension, angina, atrial fibrillation or flutter. Adverse effects: non-dihydropyridine, cardiac depression, AV blocks, hyperprolactinemia, constipation, gingival hyperplasia. Dihydropyridine, peripheral edema, flushing, and dizziness. Calcium channel blockers. Mechanism: CGMP, smooth muscle relaxation. Vasodilates arterioles, veins, afterload reduction. Severe hypertension is a clinical use. Heart failure with organic nitrates. Safe to use during pregnancy. Frequently co-administered with beta blockers and to prevent reflex tachycardia. Also, adverse effects: compensatory tachycardia, contraindicated in angina, Fluid retention, headache, angina, SLE-like syndrome. Calcium channel blockers. Hypertensive emergency. Treat with clebidipine, phenoldipan, lepidotol, nicardipine, or nitroprusside. Nitroprusside, a short-acting, it increases CGMP via direct release of nitric. Can cause cyanide toxicity, a release of cyanide. Phenoldipan, dopamine receptor agonist, coronary, peripheral, renal, and splenic vasodilation, will decrease blood pressure, increase natriuresis, also used post-operatively as an anti-hypertensive, can cause hypertension and tachycardia. Nitrates, nitroglycerin, isosorbate dinitrate, isosorbate mononitrate, vasodilate by increasing nitrics in vascular smooth muscle, increase in CGMP and smooth muscle relaxation, dilate the veins, arteries, decreases preload. Clinical use: angina, acute coronary syndrome, pulmonary edema. Adverse effects: reflux tachycardia, treat with beta blockers, hypotension, flushing, headache, Monday disease, and industrial exposures. Development of tolerance for vasodilating actions during the work week and loss of tolerance over the weekend. Tachycardia, dizziness, headache upon re-exposure. Contraindicated in right ventricular infarction. Anti-anginal therapy. The goal here is to reduce myocardial oxygen consumption by decreasing one or more of the determinants. End diastolic volume. So this is a pretty popular test question. It'll give you some scenario and ask you which is going up, which is going down. Here, pretty much all the beta blockers pretty much are going down except for ejection time. Nitrates, everything's down except heart rate. And then nitrates and beta blockers, everything's going down or there's just no effect. Verapamil is similar to beta blockers in effect. Pinadol and acebutolol are partial beta agonists that should be used with caution in angina. Anti-angle. Ranolazine, these inhibit the late phase of sodium, angina. Milrinone, selective PDE3 inhibitor. In cardiomyocytes, it increases CAMP accumulation. HMG, CoA reductase inhibitors. These are lipid-lowering agents. You could also use lovastatin, pravastatin. Bile acid resins like cholestyramine, cholestyramine, cholestyrovelum, ezetimibe, fibrates, niacin inhibitors. Cardiac glycosines like digoxin. Dioxins, these directly inhibit sodium. A indirect inhibition of sodium exchange, positive inotropy, stimulates vagus nerve, decreases heart rate. Heart failure is a clinical use, increases contractibility, atrial fibrillation, reduce conduction of AV node, and depression of SAE node. Cholinergic, so it's nausea, vomiting, diarrhea side effects, can lead to hyperkalemia. Slowly normalize potassium, cardiac pacer, anti-digoxin, Fab fragments, and magnesium as the antidote. You also have antiarrhythmics. Slow or block reduction. especially in depolarized cells, decreased slope of phase 0, depolarization, state-dependent selective depressed tissues that are frequently depolarized, like tachycardia. So class 1A, quinidine, procainamine, disopyramide. The queen proclaims Diso's pyramid. So mechanism, increase arterial pressure duration, increase effective refractory period, and ventricular action potential. Both atrial and ventricular arrhythmias are uses, especially for reentrant and ectopic SVT and VT. Synchronism, headache, tinnitus with quinidine, reversible SLE syndrome, and heart failure. Disopyramide, thrombocytopenia, torsade de pointes due to increase in QT interval. So antiarrhythmic sodium channel blockers. Finally, let's see, 1189. Class 1B, these are lidocaine, mexiltine. I'd buy Liddy's Mexican tacos. Decrease AP aorta pressure duration, preferential effect ischemic or depolarized Purkinje and ventricular tissue. Phenytoin can also fall into the 1B category. Acute ventricular arrhythmias are clinically used, especially after myocardial infarction. Digitalis-induced arrhythmias. So 1B is best post-MI, myocardial infarction. Central nervous system, stimulation, depression, cardiovascular depression is the adverse effects. Okay.